All right. Good evening, afternoon, everyone. Thanks so much for joining this evening's webinar. I know some people are still logging on here, but we'll take the opportunity to highlight that tomorrow is Canadian Orthopaedic Care Day, as you just saw. So certainly a great way to celebrate our community. Here you can see some social media posting hashtags. So certainly take some photos throughout the day. Everyone loves to see what we're up to throughout the day across the country. So happy early Canadian Orthopaedic Care Day to everybody. Perfect. And so it's my great honor to be able to introduce our faculty this evening. This is a collaboration between the Canadian Orthopaedic Trauma Society, as you just saw there. We'll post that membership information in a little moment as well, but I'm very honored to be joined. I'm Prism Schneider from the University of Calgary. I get to moderate on behalf of the COTS group, and I'm joined today. We're going to go top to bottom, beginning with the proximal femur presented by Nauth from St. Michael's in Toronto, followed by Geoff Wilkin, who will be speaking about the distal femur from the Ottawa Hospital in Ottawa, followed by Travis Marion, who will teach us all about tackling the tibia from Big Thunder and NOSM. Thanks for being here, faculty. It's great. As you can see here, we have a lot of fun through the COTS organization. We're really honored to be partnering with the COA and CORS or CORA today. And as you can see here, we're really proud of our potential membership opportunities. You can always reach out to myself. You can log on to our webpage, which is wearecots.ca. As you can see here, we're growing membership and lots of educational opportunities on the horizon. For this evening's webinar, we're going to have 3 case-based presentations, again, starting femur down to tibia. If you have questions, if you could just pop those into the chat, we'll make sure we have time at the end for reviewing all of the questions that are submitted and lots of discussion. All right, without further ado, it's my honor to introduce Aaron Nauth to get us started off.
That's great. Thanks, Prism. I'm just going to pull my screen up here. Okay. Is that showing up in the correct presenter view for everybody?
Yes.
Great. Okay. Hi, everybody. My name is Aaron Nauth, orthopedic surgeon from University of Toronto, St. Michael's Hospital. Really happy to be here representing with COTS and happy to have all the residents from across the country. We thought we'd just go over in a case-based fashion some tips and tricks for difficult nailing scenarios in diaphyseal fractures or metadiaphyseal fractures rather in the femur and tibia. I'm going to start off with talking about the proximal femur, and I'm really just going to go through a few cases, give you some insight into things that we've kind of learned over the years that the literature has taught us about how to manage these injuries better, as they can be quite tricky. So these are my disclosures. So our first case is a 75-year-old female who presents after a low energy fall. Of significant note, she has a long-standing history of bisphosphonate use for osteoporosis. These are her x-rays. You can see she's got a subtroch femur fracture, and she's got a couple sort of characteristic features for an atypical femur fracture, those being the transverse lateral fracture line that you see. There's some lateral cortical beaking as well as lateral cortical hypertrophy. There's a fairly classic kind of medial spike as the fracture pattern extends medially. And this is pretty consistent with the picture that you would see in a patient who presents with an atypical femur fracture. And these are most commonly associated with long-term bisphosphonate use, as I'm sure many of you know. I think one of the things certainly that I've learned through experience over the years is that, these look fairly simple in terms of the actual fracture pattern, right? It's a fairly simple fracture. There's no real comminution, but these can be tricky to deal with from a couple of standpoints. The first thing that I've learned is that because these injuries happen from such a low energy mechanism, the soft tissue that's around them is generally almost perfectly preserved. So they don't do any damage to kind of the muscles or the soft tissues that are around the femur. And as a result, we know that the deforming forces that you see around the proximal femur are related to those muscles, and they tend to be quite strong in these patients. So I've actually found these fractures can be quite tricky to reduce, particularly if you try to get them reduced entirely closed. And I think that's really because of this preserved soft tissue envelope. So my kind of first tip for nailing proximal femur fractures is the importance of getting it reduced. And there's really three things that you got to tackle here. So the abduction or the varus that's created by the abductors, the flexion that's created by the iliopsoas, and then the external rotation, which is created by a combination of iliopsoas and the short external rotators on that proximal fragment. And so you can see this patient we've taken to the OR, put her on the fracture table. This is what your initial AP looks like with just a bit of traction. That's not looking too bad, but when you go to the lateral x-ray, you can see we're still a long ways away from getting where we need to be in terms of getting this reduced. And you see that very characteristic kind of flexion of the proximal fragment. And so for me, this is almost always kind of jumping right to a mini open reduction. So a small incision and getting a clamp on it to get this fracture reduced so that you can mitigate all of those factors that we just talked about in terms of deforming forces. So you can see here, we're just using sort of a standard AO lobster claw forceps to get our reduction. And then we've moved ahead with our guide wire. And you can see that's allowed us to get the proximal femur out of varus, get it out of flexion, and then get the rotation kind of lined up with the distal fragment. And you can see here that at this point, we've still got the clamp on. We've gone ahead and put our nail down. And the next thing I'm going to talk about is really the key importance of this start point. You can see this nail is nice and medial. And then we're going ahead and putting our proximal locking screws into the femur here. And so this is a paper came out quite a few years ago now in JBJS in 2009 and looked at basically this exact issue. So subtrochanteric fractures of the femur and whether or not you're better off to do an open reduction. So it was a retrospective case series primarily out of Tampa, looking at 44 patients with subtroch fractures that had this technique where a mini open kind of clamp assisted reduction. You can see their union rate was excellent. So they had 43 out of 44 heal, and the vast majority had anatomic alignment. And this is a picture directly out of their article, just showing a similar technique with a lobster claw clamp, and then also illustrating the importance of that start point, which I'll go on to talk about next. And so this is our patient after that mini open reduction. You can see from the staple lines there, we're not talking about a huge cut at all, really, just a small cut to get you access in there to get your reduction clamp on. And then typically I use that same incision to put my proximal locking screws in for my cephalomedullary nail as well. And then here's that patient later on in follow-up healing nicely in good alignment. So tip number 2 is, again, back to that start point issue. So getting the ideal start point is really critical, because if you're too lateral with your start point here, you're ultimately going to end up with your fracture in varus, which is really the kiss of death in these fractures. And so what I always talk to the residents about is getting on the medial aspect of the greater trochanter. And this is really quite contrary to what we were taught, certainly when I was coming through residency and we were learning about trochanteric entry nails, which was really to aim for the tip of the trochanter. And I think it's important in general, but especially important when you're dealing with a proximal femur fracture, that you're really on the medial aspect of that trochanter. And I like this term of trochiformis, which is really kind of getting your guide wire halfway between the piriformis entry and the tip of the trochanter. And so just to illustrate that, here's another case. This is a 29-year-old female who had a high-speed motor vehicle accident. She comes in with this. You can see a bit of comminution in her subtrochanteric fracture. You can see she also had a pelvic ring injury, but we're really just going to focus on the femur. And so you can see her after a cephalomedullary nailing, that she ended up in nice alignment. But I think the thing that I wanted to illustrate here is how she's not in any varus. And if you look at the start point for this nail, it's really on the medial aspect of that trochanter, and maybe even more towards piriformis, even though it's a trochanteric entry nail. And that's allowed me to keep her proximal femoral alignment nicely out of varus. And so really this is illustrating that trochiformis start point versus what we've been taught traditionally in the past, which was the tip of the trochanter. So you really want to be where this blue line is and not where the red line is. And this is something that has been borne out in the literature. It's quite an old paper from JOT in 2005. They actually looked at this exact issue in kind of a cadaveric model and looked at all the trochanteric entry nails in the market and basically started them all at the tip of the trochanter. And you can see with all four nails that they used, that had a tendency to tip the proximal femur into significant varus. And it varied a little bit depending on the exact type of nail, but the general theme was exactly the same. And that's if you start this nail in the tip of the trochanter in the setting of a proximal femur, you're going to end up in varus. So just make sure when you're doing these proximal femur fractures, you get that guide wire nice and medial. And here's kind of an example of maybe what can happen if you don't pay attention to that. So this is another atypical femur fracture. You can see this one also has some lateral cortical beaking and transverse fracture line. In this case, the medial spike is actually broken off, but there's little or no comminution, which is sort of a common feature of these on the medial side. This patient got a trochanteric cephalomedullary nail, but you can see in this patient, the start point was really where we were taught to put it originally, which is at the tip of the trochanter. But you can see how that's resulted in this fracture tipping into quite a bit of varus. And that is an issue that's further exacerbated by the medial comminution that this particular patient has. And really, with this patient, you want to be extra sure that you're over more where my blue line is when you nail this fracture. And this, unfortunately, goes on to fail, as they often do when you fix them in a little bit of varus. And so this required kind of a major revision surgery. This is another patient, had a subtroch fracture that was referred to me, had undergone nailing at another hospital. You can see this start point is quite lateral, and this patient's ended up in quite a bit of varus and presented with a non-union and some hardware failure. And so I took him and revised him. And this can be really tricky when that start point's already been kind of made for you. So we used a plate to kind of compress him out of varus, and then went ahead and augmented, or after we had the plate and had him nicely into valgus, went ahead and put a new nail in and medialized our start point as much as we could to get him out of varus. So the third tip that I wanted to talk about was to recognize that you don't have to get your starting guide wire all the way down the femur. And this is something that I've noticed, residents and fellows have struggled with going through their training. And I think it's just recognizing that you really just have to get the guide wire where you want your reamer to start. You don't necessarily have to get it where you want it to end. And so here's another case example. This is an elderly patient with a subtroch fracture. You can see here that we've got our guide wire starting very nicely on the medial aspect of the trochanter. But if you look at where the wire is going, that's certainly not ultimately where we want the path of our nail to go, as it's heading right towards the lesser trochanter. But that's actually fine, because trying to get this nail any further down the femur, you're going to run into the pelvis. And so it's really tricky to get that medial start point and get your wire down the femur. But the thing is, all you really need to do here is ream your entry point. And so if you just ream that first couple of centimeters with the wire in this position, which is what I often do, and then take your wire out and convert it to your flexible guide wire, which you can easily make that turn and get your nail down proximally, and then your nail is starting exactly where you want it. So that's what we did in this patient. After we got the flexible guide wire down, we completed our reaming, and you can see we're again using a clamp assisted reduction. You can see the clamp on the bottom edge of this picture, but we've got the patient nicely out of varus with a good medial start point, and goes on to end up with an anatomic reduction with the start point of that nail. And so just the final thing I wanted to talk about was rotation, because this can be a really tricky thing, particularly if you have a fracture that is comminuted. And one of the things that can be really helpful is using the inherent version of your nail to get the rotation right. So all of the cephalomedullary nails that are available on the market tend to have some inherent version built into the nail. It's usually somewhere between 10 and 12 degrees, which fits nicely to typical patient anatomy, where most patients have a femoral anteversion of about 10 degrees. And so if we go back to our kind of second case, which was a young patient with a high energy proximal femur fracture, you can imagine with some of the comminution here, it may be tricky to get her rotation lined up perfectly right, but this is where the version of your nail can help you. So this is just a diagram from one of the nails available on the market showing a 12-degree anteversion. The nail that we use at St. Mike's has 10 degrees built into it. So they're all kind of roughly within a degree or two in terms of that version. And this has been described in the literature. It's something that we've been doing at St. Mike's since for a long time now, but it got recently described in the literature in 2015 and then again in 2018. And these are some pictures from the paper that went on to do an analysis of it, basically showing what you want to do is start off with your proximal cephalomedullary screws in the center of the femoral neck and head, and then you move distally to the distal femur. And what you do, and the technique that I use, is I leave the targeting guide attached to the proximal femur. I begin with rotating the distal femur until I get a perfect lateral. And then I use the proximal targeting guide to rotate the nail until I get perfect circles. And basically what you want is a perfect lateral and your perfect circle view of your distal locking screws, because then you know you're setting your femur in about 10 degrees of version. And that's going to get you, within the ballpark, within the kind of 15 degrees that we want to be in for most patients, unless they have, some dramatic kind of difference in their native femoral version, which would be something you'd look for by examining their contralateral limb before you sort of get them positioned. But for probably about 95% of patients, this trick is going to put you really where you want to be in terms of setting the rotation of your femoral nail. And this is the paper that looked at. It was published in JOT in 2018. So they looked at basically a cohort of patients where they used a traditional technique. So some of the things that we've been taught in the past is like using the lesser trochanter profile and the overlap of the patella with the distal femur. So that was their traditional technique. And then using the inherent version of the nail was what they described as the Espinosa technique, because that was the group that originally described it. And basically what you can see here is the blue line marks out a 10 degrees of antiversion. And you can see with this, using the nail technique or the Espinosa technique, all of the patients sort of clustered right around that nail, give or take 5 degrees, or clustered right around the 10 degrees of antiversion. Whereas with the traditional technique, there was a lot more variability. And importantly, when you looked at how many patients fell outside of what we would consider acceptable, so how many had their version off by more than 15 degrees, it was 30% in the traditional technique group using the lesser trochanter profile, and it was 2.5% using the inherent version of the nail. So this seems to be a much more reliable and reproducible technique for setting the rotation in your patients. And so back to our patient with the comminuted subtroch fracture, you can see that that's the technique that we used here. You can see you got a nice lateral proximally, confirming the screws are center in the head. And then distally, we get that perfect lateral coincident with our perfect circle view. And we know we've got that patient locked at about 10 degrees of antiversion. So that's kind of it. Just to go over the tips again one more time. So number one, get your femur reduced. And that includes an open reduction if needed. And especially in some of these atypical fractures where you're dealing with an intact soft tissue envelope. Number two, make sure you get the ideal nail start point, and that's on the medial aspect of the trochanter or the trochiformis. And recognize that you don't have to get your starting guide wire down the femur. You really just need to ream that entry hole, and then you can convert to your flexible guide wire. And then finally, use this trick with the inherent version of your nail to get your rotation right. Thanks, everybody.
Fantastic, Aaron. Thank you so very much. That's great. Jeff will move on down the femur. Geoff Wilkin will be presenting on tips and tricks for tackling the distal femur.
All right. Well, thanks for the introduction, Prism. And yeah, thanks everyone for logging in. So yeah, I'm going to talk about, again, Geoff Wilkin from the University of Ottawa, trauma surgeon here. And I'm going to talk about retrograde nailing of metaphyseal fractures in the distal femur. So again, the theme for the overall webinar here is, anybody, or not anybody, but most people can easily nail a diaphyseal fracture. The nail does a lot of the work for you, but when we get out of the diaphysis, things get a little more tricky. So I'm going to talk about fractures below the isthmus in the femur. Advance my slide there. So again, there's my disclosures. You may see some images of the company in here, but nothing directly related to what I'm talking about. So again, like we said, why is nailing metaphyseal fractures difficult? Well, as you heard, the nail, once we get out of the isthmus of the femur or of a long bone, and we don't have tight cortical fit on the nail's not going to do any reduction for us. That only works when you're in the diaphysis and you've got tight cortical fit on both sides of the fracture. So, and in addition to it not doing the reduction, a tight isthmic fit also provides a lot of stability to our final implant construct. And so again, when we're nailing outside of the diaphysis, we don't get the benefit of that isthmic fit for our final stability. So we have to rely on other features of the implant or other techniques to optimize the final stability of the construct. And again, as you heard in the proximal femur, as it applies in the distal femur, nailing metaphyseal fractures is really an exercise in getting an accurate start point and an accurate, reamer trajectory in that metaphyseal fragment, because that's really going to determine how well it's going to be reduced at the end of the case. So again, in my section, I'm going to talk about a couple strategies for success. Again, going to be similar themes that we heard, ensuring an accurate start point, ensuring an accurate nail trajectory, and then talk about some percutaneous reduction techniques, some strategies for extending the isthmus, and I'll explain what that means later. And then also just talking about, making sure we maximize our distal fixation. So here's a first case, younger patient. This is a 31-year-old male, higher energy, mechanism. And again, we can see, this is extra-articular, but it's definitely within the distal third, sort of the metadiaphyseal junction. It's not a simple fracture. We've got a few comminuted fragments in there, but it's it's closed, and it should be relatively amenable to a treatment with a retrograde nail. So, how do we begin? Well, it's important to remember that any intramedullary nailing is really a fluoroscopically guided procedure. And if you're going to do a fluoroscopically guided procedure, it's important that you're starting with good fluoroscopic images, because if you're not getting accurate images, you don't really know where you are, and you don't really know where you're sending your implants. So how do we make sure that we've got a good starting image? Well, a good AP of the knee, as we know, is usually we want to look at the fibular head, and we want to see this lateral cortex of the tibia kind of nicely bisecting the fibular head, so that we're getting a good AP of our proximal femur. This can be a little bit difficult when the knee is flexed. You can see we've got the femoral condyles overlapping the tibia, but that's generally a good starting point to make sure that we're seeing a good AP of the distal femur. Similarly, on the lateral view, as Aaron mentioned, we want to get a perfect lateral. And what does that mean? Well, it usually means perfect overlap of the posterior femoral condyles. We should see a nice single subchondral density, not seeing a double density or two different arcs. So we want to get a nice perfect lateral to judge our start point. And then once we've got perfect images, now we've got to get a perfect start point. And so how do we know what a perfect start point is? Well, again, on the AP, we're going to look at the intercondylar notch here. And the perfect start point, we often talk about it being as right at the apex, but it's probably a few millimeters medial to the apex of the notch. I'll show you some information on that in a second. And then on the lateral view, we're really looking here right at that sort of apex of Blumensatz's line. Those two cortical densities is kind of really where we want to be starting on the lateral view. And so again, when we're looking actually on the AP, as I say, we often think about it being right at the apex, but we've got some anatomical studies showing that in most people, if you draw a line of best fit through the distal metadiaphysis, the anatomic axis actually extends probably a few millimeters medial to the apex of the notch. And in the vast majority of specimens, that's the case. In a few people, it is truly central, but it's important to recognize that it is never lateral to the apex of the notch. So when you're getting your start point, getting your starting guide wire, you definitely want to keep that in mind. It's certainly ensuring that you're not lateral to the apex of the intercondylar notch. The other thing that I think that practically means is, when you're choosing a surgical approach, I think that this is an argument for choosing a medial parapatellar approach rather than a tendon splitting approach, because this likely puts you more in line with that distal extension of the anatomic axis. You're less likely to be fighting the tendon to get that sort of anatomic axis trajectory that you're aiming for. But so that's my personal approach, is to usually always favor a medial parapatellar for that reason. Okay, so now that we've got a good start point, now the next strategy is we got to make sure we get a good trajectory. And so in the distal femur, what does that mean? Well, on the AP, it's basically a straight line, and we're essentially aiming for the midpoint of the canal in the diaphysis. And in this fracture, we've got a reasonable amount of diaphyseal bone, so we can approximate where that is. But as fractures get more distal, that can become difficult. And so it's really, trying to aim for, about 9 degrees of valgus, as a normal distal femur should be, and making sure that we're not kind of perpendicular to the line across the condyles. On the lateral view, it's a little different. We generally don't want to aim directly in the center of the canal. Most of the time we want to be aiming a little bit posterior, so we're paralleling the posterior cortex to avoid putting the femur into an extension deformity. And again, we'll talk about that in a second. Now, for those of you that are very critical-eyed, you might say, well, Jeff, where you've drawn these lines aren't exactly where you've described them. And I think you're right. A better trajectory is probably this line. That would be more central. And a slightly better trajectory would be like this. But this is pretty close, right? So we're going to start it. We're going to ream. We select our nail, and we put our nail up. And we get something that looks like this. And so this doesn't quite look right to me. It's okay, but something doesn't quite look right. And it looks like it's probably in a little too much valgus, And again, if we look at the cortical lines, you can really see that isn't quite lining up the way we want it to. But the nail's in, so how can I fix this now? Well, this is a perfect scenario where we can use blocking screws to modify the trajectory of the nail that we've already created. We've got a deformity that's induced, and we want to redirect that into a better alignment. So again, this is our reduction we've got. You can see I've got my knife kind of overlying where I think I want a blocking screw to be. And then what we're going to do is basically we're going to drill with the nail in place so that we know that we're actually going to hit the nail with our blocking screw. Once the drill bit hits the nail, then we're going to take the nail all the way out, finish drilling to the opposite cortex. And that way we know that the screw is actually going to do something. What we don't want to do is insert a blocking screw too far away and it doesn't actually do anything. So this ensures that we actually are going to intersect the path of the nail. And then once our screw's in there, then we're going to reinsert the nail, and the screw is going to force the nail into a better path, something that looks like this. And again, you can actually see I had to do this twice. We've got a little screw hole there from our first one, still didn't like it. So we actually put a second blocking screw to keep forcing that nail over until we were happy that we've got those cortical lines better and we've got a more appropriate amount of valgus in the distal femur. So that's what that looks like at the end result. I'm feeling pretty good about myself. This looks great. Blocking screw worked like a charm, and I get my final lateral, and it looks like this. And I thought, oh, geez, I didn't pay attention to that. So it's a reminder that we've got to pay attention to both planes. And what this really needed was probably another blocking screw right here to accomplish the same thing in the sagittal plane. Now, and then again, that would force that fragment up into that. Now, we didn't do that. He went on to heal reasonably well, but with a little bit of an extension deformity. And I highlight this because this is a common issue in distal femur fractures, this sagittal plane extension deformity. And just like in the proximal femur, we've got muscular attachments on that distal fragment that want to pull that fragment into extension. And then this can also be exacerbated due to nail bow mismatch. Our femur naturally has a bow to it. And the medullary bow is a little bit more than the bow along the anterior cortex. This varies from people to people, a little bit more in males. There's some general statements that, as people get shorter, they have more bowed femurs. People of Asian descent tend to have more bowed femurs than white or black populations. And then the other thing is that different nail manufacturers also have different radii of curvature for their nails. And so it's really important to know your implant. And why does that matter? Well, conceptually, here's a femur. The femur's got a canal that has a given radius of curvature, but we've got a nail here that's got a slightly different radius of curvature, the actual canal. And this is particularly a problem when the femur is more bowed and the nail is relatively straight, because when I put that nail in, you can see it doesn't quite fit the bow. And what it wants to do is sort of sit along the back. And that's where, when we're talking about getting our initial trajectory, we want that sort of hugging the back of the femur to avoid putting it into an extension deformity. Because what that looks like, again, here conceptually, is here's the femur with its native bow. We've got a fracture of the metadiaphysis, but I've got a nail with a radius like this. And I can't put it in like that. It has to start in the appropriate start point, and it's going to go like that. So the only way for this to work is that the femur has to extend through the fracture site. And so, again, just being mindful of patient's femoral bows and the bow of your implant. Other things, again, percutaneous reduction techniques, I'm a big fan of. Definitely we can do an open reduction. You don't want to leave without a well-reduced fracture, but certainly I'll try to do everything I can to avoid doing an open reduction. And here's a case where that's particularly applicable. We've got a periprosthetic distal femur fracture. You can see we've got a very large soft tissue envelope. So this is not someone that I'm super keen to do a open reduction on. So we can do things like joysticks or Chance pins to help directly manipulate those fragments. It's nice to get direct control of the fragment if we can. But if we look at this patient, we've got a relatively distal fracture. And if I go to put a joystick like this to take it out of that extension deformity, you can see that fracture extends right to the flange of the prosthesis. So I don't really have any real estate to put one in like this. So another technique we can use is actually a percutaneous traction wire. So again, the distal femur has a center of rotation around the condyles. We put a little traction wire here, anterior to that center of rotation. Kind of looks like this. There's our traction wire traversing the femur. And then now all we need to do is just gently pull on that tracture like this. And because it's anterior to the center of rotation, it's going to cause this to rotate this way and do that for us. So that's a really easy way of getting out of that extension deformity that we'll often see. So again, this looks great, but we get an AP, and ODR looks like this. So now how can we fix this? Well, again, we know that the fracture has a long lateral spike. And this looks like a perfect spot to put a clamp. And again, here's a percutaneously placed clamp. So again, this is through 2 small stab incisions, no big open incisions. We're going to preserve that fracture hematoma environment. And we can just push that over gently until we correct that plane of deformity as well. And then now our nail can go up. Now you'll see here, I've got a screw up here, and I'll tell you that this wasn't put in as a blocking screw. I put this in after the nail was in, compared to our blocking screws that go in before our nail is finally seated. So what's this screw doing? Well, again, this screw is extending the isthmus of our fracture, and this is going to help with overall stability. Because again, in metaphyseal fractures, we don't have any cortical contact for stability. This is another example of the same technique, very distal fracture. We've got a capacious metaphysis. And again, we're using biplanar screws to extend the isthmus in the long segment to enhance our stability. And there's been some research on these. People call them bell clapper screws. And it does improve the overall stability, particularly in older patients with capacious canals. So again, I have a low threshold to put these in. And again, these go in after the final reduction, after the final nail position. And basically all you're doing is it improves the overall stability of your implant construct. And then the last point I'll just make is that, again, related to this, when we're nailing distal fractures, because we don't have any isthmic fit, we're entirely reliant on the interlocking screws in the distal fragment for angular stability. And so, we really want to maximize every possible way of getting angular stability. So that means putting in essentially every distal screw available. Some implants, you can actually lock the distal screw with using an end cap. Some implants have angularly stable screws. Some implants even have a locking side plate that you can attach for additional angular stability. So again, really knowing your implant, and, sometimes at the end of the case, it sort of feels like, 2 screws is enough, maybe 3 screws is enough. I would really advocate put in every single screw in that distal fragment. Again, because you're not getting any angular stability from an isthmic fit. So just a few little points, but again, in summary, again, it's important to remember that the nail is not going to reduce the fracture for you. Reduction is really dependent on what you do as a surgeon, and that means getting an accurate start point, an accurate trajectory, using all the percutaneous reduction techniques you know about, and then again, doing things like bell clapper screws and maximizing your distal fixation to make sure you're getting the most stable fracture environment possible.
Fantastic, Jeff. Thank you so much. That was an excellent overview. We're going to move further down the lower extremity to the tibia, and it's with great pleasure that I get to introduce Travis Marion to speak with us about that. Thank you. Just while we're popping that up, Travis, if you have any questions, any of our participants, thanks so much for joining. Just pop them in the chat and we'll have lots of time to address those questions after this presentation.
All right, I hope everyone can see everything here. Thank you for the opportunity to present. And I think this is really going to be a similar theme in that we want to maximize our start points. We want to understand our start points. We want to understand our implants. We want to minimize soft tissue injury and kind of maximize whatever percutaneous techniques we can and try to achieve that distal fixation. No relevant disclosures for this talk. Um, and so, while there's a lot of different tibial fractures that may occur, obviously, as Jeff said, the isthmic or diaphyseal fractures are less of a concern in that, the implant does a lot of the work for you. There is certainly the proximal third metadiaphyseal fractures. I'm not going to talk about those. I thought I'd really focus just on the distal third in this scenario. And when you think about what our considerations are, I think it's everything from position and approach. And I think that's kind of shifted, at least since I've left residency and certainly fellowship. The reduction fit techniques, certainly when you're thinking about the deforming forces in the proximal tibia, you're going to have to consider those when you're trying to achieve your reduction. Imaging and start point, your fixation, your post-operative care, and of course, trying to avoid the pitfalls throughout all of this. And what are the potential adverse events? If you could try to anticipate those, then hopefully you can try to avoid them. And yes, we have all those, adverse events that, you as junior residents are going to rhyme off the top of your head, DVT, PE, vascular injury, neurologic injury. But really what's specific to the fracture that you are currently treating. And, in tibias, we're looking at anterior knee pain, malrotation, and malunion. Malrotation more specifically for the distal fracture patterns and malunion more with the proximal ones. Again, thinking of those deforming forces. And of course, non-union. The other thing to think about probably more with the tibia is, of course, that soft tissue envelope. I'm not going to be talking about open injuries, but certainly there's less of that soft tissue envelope. Don't forget to rule out open injuries, those little pinhole pokes, those types of things. And similarly, I think you have to have just a little higher degree of respect for the soft tissue envelope, especially when you get down to that proximal tibia, or sorry, distal tibia. So, just one case here to start, 42-year-old male, tobacco use, recreational drug use, fairly labor-intensive job, was in a motorcycle incident, has this distal third tibia fracture. And you can see it was kind of multi-fragmented spiral, getting down really low. You always want to get those orthogonal views, of course, and you want to make sure that you have full imaging. And, when we think about this fracture, the first thing that has to cross your mind is how far does that extend and what investigations do you have to order next? And in this scenario, you can see that the CT shows that the fracture pattern comes down as far as, a certain degree, and it actually stops. But then we have additional fracture pattern down below. And so I think that's one of my tips is, make sure that you're defining your injury and the injuries associated with this, whether this is a fracture that continues down and becomes an intra-articular fracture, or is there a separate fracture in and around the ankle? We know that, based on whatever study you're looking at, probably at least a 25% chance that there's some sort of extension with these distal third fractures. So I like to get a CT with these to rule them out. But again, if you're in a center where the CT is not always available, you could look under fluoroscopy just by externally rotating and trying to get, may not be exactly that degree, but you may want to try to get that fracture plane in line with your imaging. And certainly that can help you intraoperatively as well. And so the other reason I like to get the CT is just for my pre-op planning. As both the previous speakers mentioned, you really have to know your implant. You need to know how much fixation or what your fixation points are distally and how far are they from the most distal aspect of your fracture. We want to try to maximize this distal fixation with as many screws as possible, possibly augmenting these with things like the bell clapper technique. If we think about how these function, as Jeff said, you can't really rely on that isthmus We have to think of it almost as a mop in a bucket, is how they're often described. So you can have that nail right down the pipe of your isthmus, as it will occur with an intramedullary device. But if you don't have control of that distal fragment, it can go absolutely anywhere. So you have to think about is the intramedullary nail the proper fixation for this? Do you need to do a hybrid construct, or is this something that we should be considering even plating, right? So some indications as well as some relative contraindications. And this has been investigated. I think we'd be remiss not to talk about these, that there is good literature to support fixation, minimally invasive plating for these types of fractures. For me, I like to have, well, I think most people now are supine on a radiolucid bed. I actually prefer a Jackson flat top. Maybe it's because I'm a spine surgeon my other half of my life. But you want something that you're going to be able to get your full radiographic view from, both in your AP and lateral planes. I like to keep a tourniquet on, but I don't inflate it. Again, there's always that concept of perhaps an osteonecrosis when you're reaming. And then what's the approach? There's a lot of different approaches, and I think I've seen most of them throughout the course of my career. Everything from the medial parapatellar to the infrapatellar, to now what is a suprapatellar, which is gaining more and more, traction, and certainly true of the distal fractures. I think there's a better ability to control your alignment with that. And I think that's been demonstrated in a number of studies. And I believe, in Thunder Bay, where you may have limited assists, I think it's also easier on that assist. You can really only have to really apply that traction more than anything else. Before I even talk about the approach, I'd be also remiss if I didn't talk about our COTS study investigating this. The other benefit of that suprapatellar nail is, potentially minimizing some of that anterior knee pain that may occur. Before I even open the open an incision for an approach, I actually want to get that reduction first. Number one, you're going to be minimizing blood loss, but if I'm going to spend time doing anything, this is what I'm spending time doing. And so there's, everything from manual traction to percutation, reduction forceps, which is often my initial start. May need distractors if it's particularly bad, or you need to have further length. Blocking screws can help you certainly in that distal fragment. Plating the fibula, especially if you need to restore that length or get better alignment or help you with that reduction, and then open and unicortical plates, pretty much my last option. And unless it's an open injury, I'm trying to avoid that at all costs, especially around that distal tibia. So here's just an example of us using that percutaneous technique with the forceps in order to try to better align the fracture pattern itself. And as Jeff mentioned, you want to make sure that you just really have good images intraoperatively, both of your ankle and, of course, ultimately of your knee. I'm just going to adjust the views here. You can see this one here already has that ball tip guide wire down. But really, like I said, I want to get that reduction before I even open up the incisions. We talked about start points, and that's especially true of the tibia, especially when you're talking proximal, but I think it's true of any fractures with the start point. And we do know where it's supposed to go. It's supposed to be on the medial aspect of the lateral tibial spine on the AP and below the articular margin on the lateral. So we have, and you want to make sure you have the proper images. Once again, you want to have that 50% overlap of the fibular head, because as you rotate that proximal tibia, you may actually be changing where your true start point is. You think you're on the lateral aspect of that, medial aspect of that lateral tibial spine, and in fact, you're not. Here's that image intraoperatively from the lateral. Again, overlapping femoral condyles, nice congruent tibial plateau. And this is with the point that we're trying to hit to avoid any additional structures. With the suprapatellar nailing, I think it's absolutely paramount importance, whether it's you or your resident or your assist, whoever's kind of managing the soft tissues to always keep that soft tissue guide down and do not let that move. And if it does move, you reimage. I do find that depending on how tight that knee is, getting that start point can be a little difficult. Sometimes I'll carefully put that guide wire in first and then the soft tissue guide over top with the inner sleeve on it, just so I'm not damaging any cartilage. Like I said, that sleeve does not move. Your hand's on lock. You want to have your suction on it, so you're always trying to pull up any of the reamings as well. Guide wire insertion. So I like to bend my guide wire. I find you can kind of direct it a little bit better. And the question is, where does it go distally? Does it just go, center? What does center mean? And that has been described. I like to think of it as Marion point because I described it, but I didn't get my paper out fast enough. And so we got beat to it. But essentially, if you're looking at it on the on the AP, on a mortise view, it's just slightly lateral to that center point. And sorry, I didn't take the other shot. And then you want to be center on the lateral or even slightly posterior as well. And so that's the point that you're looking for, especially with those distal tibial fractures, because of that kind of mop in a bucket phenomenon. This is the trajectory that is in line with the isthmus. And that study that I've shown outside of those parameters is really what contributed to malunions or malreductions. Confirming length, you're going to have to, this is just for all the juniors out there. I think you have to know your implant. It'll never be right on what you need it to be. I like to make sure that my measuring device is below the level of the surface. And then, the particular implants we use, I tend to upsize them, especially if it's a very distal fragment. So if it's between sizes, I just go up to the one above. I spoke about reaming already. Getting up to that chatter, we want to use reamed implants, get that higher diameter nail in there. And as you're putting that in, you really want to make sure you're controlling your rotation, ensuring that the percutaneous aiming guide is in line with your crest of your tibia and in line with your second metatarsal head. And I don't like to turn that as you're advancing it. Statically, I want to turn that as I advance it. In terms of proximal fixation, I always go 2 unless it's really length stable. And in fact, unlike this picture, I like to go entirely from the medial side. I find that even in the most robust soft tissue envelope, these kind of anterior oblique screws can be a little prominent. Distal locking fixation we've talked about. I try to minimize my incisions in order for that drill not to go all over the place. And I want to maximize my distal fixation and get those really good distal screw fixation. Now, this particular patient did have that distal extension into the posterior mal. I opted not to operate on it. I did not, or achieve fixation. I did not think it was clinically relevant. I didn't change their ambulatory status. Really, what I'm looking for is the size of the fragment. Does it contribute to ankle instability? Will this displace? My goal is to try to weight bear the patient as soon as possible. Here they are at probably about the 6-month mark. You get a nice buried nail. You're not contributing to any anterior knee pain. When I do close, I like to wash the joint out with pulse lavage. I have seen, kind of ossification in the joint after. And, post-operatively, same as any other intramedullary device, we're going to have some weight bearing right away and range of motion as tolerated. So in terms of the pearls and pitfalls, I think you want to evaluate for intra-articular fractures. Sorry, I spelled that wrong. You want to ensure that you have the start point suprapatellar for your distal third, multiple distal interlocking screws, fix the fibula if it improves the alignment, and repeat and confirmation of reduction throughout. Here's another quick one. So kind of more of a distal third again. It does involve the isthmus a little bit more. This is your typical Thunder Bay patient in that they were on meth and fell or was pushed off a balcony. And when you actually look at that distal fracture, it is more of a complex intra-articular pattern. And so here I used, I don't know if you want to call them necessarily blocking screws, because I don't think they really contributed to a fixation, I'm sorry, to the reduction. But, serve to achieve some fixation as well as serve maybe as a bell clapper aid. And ultimately, let them weight bear. And, they must be doing well because I've never seen them again. I think when we talk about pitfalls, here's a good example of one. There's a crush injury, multi-fragmented, critical bone loss, and it's probably done in the middle of the night, and you never want to criticize someone where you weren't there. But if you think about some of the things we discussed, we could have maximized more um, distal fixation, of course, improve on that overall alignment with likely some blocking screws. And I suspect that a fibular plate would have improved on this overall alignment. Ultimately, they had to go on for a revision. Thank you.
That was fantastic. Thanks so much, Travis. Big thank you to all three speakers. Those were excellent pearls. So for the participants, if you have some questions, pop those into the chat and we'll certainly address those. Maybe what we'll do is start sort of top to bottom. So Aaron, I'll come to you. Really love the summary of the reduction tips, the importance of the start point, have technical tricks for getting rotation correct. Can I ask your sort of positioning for choice for that proximal femur fracture? Are you someone who's exclusively lateral, on the fracture table, supine? Does it depend? What really guides your decision making for positioning?
Yeah, it's a good question, Prism. I'm kind of a Hannah table guy, so I tend to do these in traction, and I like having the leg locked in traction. But interestingly, I have a fairly significant revision practice. When I do a revision, then I always convert to kind of a lateral position to revise them. But for the fresh ones, I like to go with just the fracture table and subtraction.
Excellent. Thanks so much. And maybe I'll just kind of poll Jeff and Travis, your thoughts for that proximal femur positioning.
Yeah, I can go first. I have a different approach. I often, for a subtroch or a proximal femur fracture, I'll usually just go supine on a flat top table without, not a traction table setup. So just supine on a flat top table with a bump under the hip. And then in terms of getting traction, if you have sufficient assistance, you can have someone pulling traction. You can also put in a, traction wire and run traction off the end of the bed. But I like that position because usually for those, I'll try to aim to do a piriformis entry nail. And I find that it just gives me easier access. I can, again, use a percutaneous joystick, really adduct the proximal fragment to sort of deliver that start point easier. And I find it just easier to do that with the leg free rather than on the fracture table.
Great. Thanks, Jeff. Really nice pearls. Travis, what are your thoughts?
I'm on fracture table. Part of it is, access to assist intraoperatively. I also just like to have, I don't use a shower curtain. I split drape them all, and that gives me almost, probably somewhere around 240 degrees to 70 degrees of access. So if I need to use those tips and tricks like joysticking, making a small little incision to get a cob in there, bone hook, I have access to that.
That's great. And I think what I really heard from the speakers uniformly across the entire lower extremity is, a stepwise approach to percutaneous reduction tools, really regardless of which position you're in. So you've seen some tips and tricks for both. Question from our participants here. What are our thoughts on sort of the intermediate lengths that are now coming out from various companies as far as proximal femoral fixation? Indications for sort of that shorter versus intermediate versus long cephalomedullary implants. Aaron, maybe I'll start with you.
Yeah, I don't know what the right answer to that one is. I can say that I haven't used it. I tend to go long for the vast majority of my nails. We're definitely starting to do some more short nails for kind of intertroch fractures, but certainly anything with any kind of subtroch extension, I'm going long nail.
Sounds good. Jeff.
Yeah, We use that. I often use that 225 nail a lot of the time, actually, for a lot of intertrokes. I think where it's probably most beneficial is the intertroke fracture with a very large sort of posteromedial fragment, where you've got a large lesser trochanter fragment that extends several centimeters below. And I think that's helpful, particularly when you have an older patient, again, with a very capacious canal. I think the question was about the Synthes nail. That nail just only has one distal interlock. And so when you have a capacious canal and you don't have that posteromedial support, what you can often see is the nail will sag and toggle around the interlocking screw. But by having the nail go longer, I think you get, because you're engaging the diaphysis a bit more, you're less likely to see sagittal plane translation. So that's kind of, I think, the best indication for it if you don't want to go to a formal long nail. But yeah, that's kind of when I'm using it.
Yeah,
Makes sense.
I agree. I think we might be the last place that's still using dynamic hip screws. So if I don't have the most simple retrochanteric fracture, it involves kind of that posterior aspect, or significant involvement of the LT and whatnot, then I'm going to a shorter nail. I still ream it. I don't just put it in. At least when I've seen short nails initially applied, I don't think we always use the same, or at least we didn't have the same respect for the technical challenges of getting the reduction or anything like that. It was just toss them in and hope for the best. And I still think all the points that were made so far with the proximal femur apply with the short nail. I don't think it's just a quick means to the end.
Yeah, agreed. And maybe just to follow up on the point was made earlier about know your implant. And so it's really important to know where that sort of distal interlocking screw is. If there's any propagation of the fracture line below the lesser trochanter, be really cautious of that, because you're really relying on that single point of fixation, and you're potentially losing some of that isthmic fit with the shorter ones. That's maybe what the intermediate lengths is trying to address a bit.
I have to say, I really just don't get the intermediate nail. Like, I really, I don't get it. Like, it's like go long or go short. Why are we going in between? I don't really know. It's also a bit. It seems like Jeff just wants to say the opposite of everything I say. So
This is why it was a
it must
perfect.
be an Ottawa versus Toronto thing. It's like a Sens versus Leafs kind of thing going on here.
Yeah.
Um,
It wouldn't be a very interesting webinar if I agreed with you all the time.
fair enough. The one thing is, that it is somewhat counterintuitive, right? It is we always talk about kind of stabilizing the whole femur, right? And to me, the isthmus, or sorry, the intermediate nail, or the short nail for that matter, leaves a lot of the femur unprotected. And it's funny because we went through this whole thing where, it's like, oh, if we're fixing a distal femur, we got to throw the plate all the way up and protect the femoral neck. And now all of a sudden we're doing the proximal femur and we're going a third of the way down or halfway down. Whereas, often in that patient population, I like to take the opportunity to get the nail all the way down. But I recognize that there's probably not good evidence in terms of which of those implants is better for proximal femur fractures. I think for sure for the residents, if you have that subtroch extension, I don't think a short nail is the way to go. And whether an intermediate nail is kind of a reasonable step, or a long nail, but I think you got to pick one of those two, and don't be doing a short kind of nail, like a standard short nail with significant subtroch extension. Would you guys agree with that?
Yeah, I
Yeah.
think it's an important distinction. I would say I would say that I don't think there's a role for a short nail in a subtrochanteric fracture. I don't think that's a controversial statement. I think there's a flavor of intertroch fractures that is maybe amenable to that intermediate nail, but that's an intertroch fracture is a very different beast than a high subtrochanteric fracture like the ones you showed. Those is always a long nail in my books for sure.
Agreed.
Okay.
There we go. Perfect. Okay, let's swing down to the other end. We have a question that I'm sure is on many participants' minds. So how do we address that posterior malleolus fracture that you identify on your CT scan, or even on your preoperative imaging in that distal third tibia? So which ones are we percutaneously clamping, fixing? Maybe Travis, we can start with you.
Yeah, I don't, it's probably something I struggle with. It's whether or not, number one, does it contribute to, ankle instability? Is it a part of a larger fracture pattern like in that, last case I did? Is it a small little avulsion? Is this going to be clinically significant? Is it going to change my weight bearing? Am I afraid of me putting a nail down and I'm going to blow that apart? I think those are all very different um, considerations to have. And then there's also the difference between that distal third fracture being an extension into the articular surface and what plane is that in, because it can be a variable plane. It's not always in that coronal plane. It could be in the sagittal plane, in which case, maybe your implant takes care of that, versus a separate fracture altogether. And so those are kind of the considerations I have when making it, or sorry, when trying to make a decision. I don't know if that's really answered your question, unfortunately.
No, I like it. And you really highlighted, you have to understand the constellation of injuries for these distal third tibias. So is this an ankle plus a distal tibia, or is it a distal tibia in isolation? And I think that can potentially guide some management. Jeff, what are your thoughts?
Yeah, I think similar. I think that classic sort of spiral distal third, the way I think about it is this was trying to be an ankle fracture and it turned into a tibia fracture, right? So the reason you see the posterior malleolus is because it was trying to be an SER, like a supination external rotation pattern, but then the force kind of got directed further up the tibia. So like Travis said, is that if you would fix the posterior malleolus in its own right, if it was an ankle fracture, if you have an associated fibular fracture that's accessible, I think it makes sense to fix the posterior malleolus, especially if it's displaced at all. I mean, if it's displaced, then you probably need to do something to more directly reduce it. But I think the question is more like when it's undisplaced, do you put a percutaneous anterior to posterior screw? Again, I think for me, it probably depends on the size. And am I concerned that when I put the nail down, is the nail potentially going to end in the fracture plane? And do I want to have it secured before the nail goes down? Because I think the reality is that most of these are usually undisplaced or minimally displaced, and they're probably pretty stable. So I'm not sure that they all need fixation, but when they get larger and they're potentially the fracture plane is in the path of the nail, that's where I start to think about it, about fixing it first before the nail goes down.
Aaron, anything further?
Yeah, I would just say I'm maybe a little bit more aggressive with putting a screw in it because I'm more paranoid that I'm going to displace it with my nail. I think, kind of anything more than 10 to 15% of the articular surface, and that they can be a real challenge to, get a percutaneous clamp around and get them reduced if they do move. So I think, the extra 5 minutes to throw a screw in it. And I don't get super fussed about the screw being in the way of my nail because I tend to put that screw kind of right at the physeal scar, which is where I'm going to end my nail anyways. I think Travis, you showed kind of a nice picture of putting it on either side of the nail. I tend to just put it a little more distal and then not worry about it a ton that it's going to get in the way of my nail. But maybe just a little bit more aggressive for me with putting screws in them.
That's
Or most, I must say, most commonly a screw. It's usually one screw.
Yeah. And then maybe I'll follow up because Aaron, I'm a little bit more similar in that sense. And we are looking into this because does it have functional outcomes? How often does it displace? I think some of these questions aren't actually answered. Are you using interop C-arm to then plan your trajectory? Are you always getting a CT scan so that you can plan that kind of perk super distal screw?
Yeah, I think, and for me, just like Travis said, any kind of distal third tibial shaft, I would get a pre-op CT on to pick up that 25 to 30%. And like Jeff said, they're often undisplaced, so you're not necessarily going to see them super well on your x-ray. So I usually get a CT scan and then I look at the axials, just like Travis showed, to plan that trajectory of my screw, how much lateral to medial or medial to lateral, sorry, that I want that screw to go and kind of even measure too, right? I think this is going to be a 40 screw kind of thing.
Awesome. Sounds great. Well, I think with that, we're just past the hour mark. Fantastic discussion, excellent cases. Big shout out to Matthew Menon and Helena Green, also members of our COTS Education Committee that have joined us this evening. Big plug for Canadian Orthopaedic Care Day tomorrow. So check out the COA website. Certainly tag the COA in anything that you're up to tomorrow, and then check out COTS. We are cots.ca, all one word. See what we're up to. Lots more educational opportunities in the pipeline. Thank you all very, very much for joining. Thank you to the speakers. That was excellent.
Good night, everybody.
Thank you.
Thanks, everyone.
Thanks, guys.